call you just for care. All right. So we can wait him. So Dr. Nabhan, you'll enter the exam in November or September in Ireland?
In November.
In
England.
November, England, UK. All right. Dr. Iman, you attend in which time? Okay, no problem.
Maybe Dr. Man is not connected.
Yes,
maybe it will
yes, no
reconnect again.
Yeah, sometimes we have a bad connection here in Egypt and outside Egypt.
Yeah.
Yeah.
All right.
We can start with Dr. Nabhan to be ready for
Okay.
November. Okay.
Okay. So this is the scenario. You can see the scenario. It is a 65 years old male, severe lower abdominal pain, fever, 7-day post-operative post-left hemicolectomy. So you just take a focal history. We ask you to examine the patient. We ask you some question. So you can start, for example. You can
Okay, so this is an examination?
No, actually, this is not examination. I tell you at the end.
Okay.
Because if you read it, what you expected. No, not now. We finish at the end. We tell you. Okay. It is focus history. Maybe just inspect the abdomen, and it is at the end we know that what is this station. Because I think one of the staff, Dr. Corollos, he entered it and he expected something else. Hi, Mariam. So you can start now. You take a history first. Just a quick history. Dr. Nabhan.
Okay. Just give me a minute to read the...
Okay, so it is a male patient, has a 7-day post-operative after left hemicolectomy. They have severe abdominal pain and fever.
Okay, good morning. My name is Dr. Muhammad Nabhan, one of the surgical doctors.
Good morning. Yes.
May I confirm your name and age, please?
Yeah, I am Mr. Limb. I am 65 years old.
Good evening, Mr. Limb.
Yes.
How can I help you today?
No, you can ask me. I have fever and abdominal pain.
Okay, can you tell me when this fever started?
Just today. I have operation done 7 days ago. This is a 7 day or 7 day of post-operative. I have fever today and abdominal pain mainly in the left side.
Okay, that's after the operation of 7 days?
Yes.
Okay, did you take any medication for that?
For what? For pain?
Yeah, for pain and for the fever.
Yes.
Okay, did you feel any...
No, I'm not improved, and I think the doctor will ask me to do another surgery or something like that. I don't know.
Okay, so can I just come beside you and I will just have a look to your abdomen?
Okay, you don't need to know what is this operation.
I think it's written here, it's a left hemicolectomy.
But it is for what? You need to ask, or okay, you can know. All right, if you look to my abdomen, you can find I have just abdominal scar, and I have no drain, and because the doctor removed the drain 2 days ago, and also I have no colostomy.
Okay.
Okay. All right. So I can start to ask you because, okay, this is the history. So in physical examination, as I mentioned, they have abdominal wound, no colostomy, is a site of drain. And after that, the abdomen is little rigid. So this is 7-day fever. So can you tell me about what is fever and what is a post-operative fever mean?
Yeah, it's fever mean increase in the core temperature of the body more than 37.5 Celsius.
Okay. So it's from the starting from the day one. What is the possibility to have post-operative fever?
Yeah, it can start from the day 2 for infection.
Okay.
And day
Which
5 for
infection?
absence. Skin infection, like
Skin infection usually occur in the 5th day because the wound bacteria have incubation period. So to have wound infection, you need 5 days, except in necrotizing fasciitis, which is rare.
okay.
What is fever due to 2nd day? Could be what?
Could be might due to chest infections.
It is lung atelectasis, not chest infection. Chest infection in the 5th day. So the 2nd day can be lung atelectasis or lung collapse. 5th day, what is the possibility in the 5th day?
Maybe anastomotic leak.
Anastomotic leak. What else?
Uh,
Can be
abdomen.
tract infection. So I just show you the list. So we have a big list here. I think this is down. So we can have 1st day or 2nd day can be body response to trauma. 3rd day, 2nd day can be lung atelectasis, start chest infection. 3rd to 7th day chest infection, wound infection, anastomotic leak, intraperitoneal sepsis, UTI. 7th day DVT. After 10 days can be pulmonary embolism. Okay. So back to the history again. You need to ask me what is the indication, what you expected. You need to ask me or look to the notes. What is the cause of left hemicolectomy?
Okay. So
Indication.
what are the indications for left hemicolectomy?
Yes.
It might be a mass in the
You mean
distal
cancer.
colon.
You mean cancer.
Yes,
Cancer in the colon. Or what else?
It might be diverticulitis.
Or can be diverticulitis, or can be cancer colon. Okay. When you ask me in the history, I tell you I have no colostomy, but I have drain. So this is correct to don't have colostomy, you have left hemicolectomy, or it is wrong?
Usually it's wrong because the left
Yes, so I
hemicolectomy.
must have colostomy. Okay. So now what is your diagnosis? If I don't have colostomy, so what is this?
So it's anastomotic leak.
Anastomotic leak. Okay. So how to check this is anastomotic leak or not? How to confirm?
I will start with abdominal ultrasound.
Before abdominal ultrasound, I mentioned to you that I have a drain.
Yes, I will just take.
So what time we need to remove the drain if you have drain after hemicolectomy?
At least 10 days.
Yes. Why? Because what is that usually time of anastomotic leak?
It's usually on the 10th day, 10th or 11th day.
Usually after 5 days. Started from 5 days. So that usually we don't remove the drain. In other part of body, we remove the drain when nothing come from the drain. But after that, so the wrong here, they remove the drain before the 7th day. So you must leave the drain even not come, because anastomotic leak, if occur, can occur late. Okay? All right. So how to treat this patient? Of course, we're looking for the abdomen is lax or rigid. We're looking for the drain. The drain is removed, which is wrong. We're looking for the vital chart, so pulse, temperature, blood pressure. What's the investigation we need to do for this patient?
Okay, I will do a full blood count.
Looking for what?
Looking for leukocytosis.
What else?
I will look also for lymphocytosis.
Baseline investigation, and you mentioned abdominal ultrasound. Okay. What else you need to do?
Other than abdominal ultrasound?
No. In lab investigation, important in critical patient. Something like
urea and electrolytes.
What else?
Liver function tests and
Okay,
CRP.
we have this blood gas. CRP is non-specific. We have this blood gases to you. Can you comment on it?
Yeah, the pH is 7.2, so there's acidosis.
Yes.
And bicarbonate is low, so this is a metabolic one.
Okay, so it is metabolic
acidosis.
Okay. All right. Okay. So we order ECG for this patient. The upper one is the patient ECG. The lower one is other patient. So what is your diagnosis?
The lower one is normal, not this patient.
The lower one is normal, not this patient. Our patient is the upper one. What is your diagnosis?
I think there is an absent B. So it might
Is
be
absent or multiple P? What is your diagnosis here? If you have multiple P, what we called it canal pole P, something like this.
Okay.
Yes, it is atrial fibrillation. Okay. So can you tell me what is your management now?
for
this
atrial
condition of the
fibrillation.
patient? No, we speak about the patient as a whole.
Okay. For the patient as a whole, I will transfer him to the ICU,
Okay.
and they will start with the empirical antibiotic.
Empirical antibiotic. How many antibiotic you give? 1, 2.
I think 3 at least.
Which type of antibiotic? We don't give 3. Usually a maximum 2. 1 for aerobic, 1 for anaerobic. Can have a sample or example. For example, like what?
I think fourth generation cephalosporins.
And
for gram-positive, we might give
for
ampicillin.
anaerobic, metronidazole.
For
Usually give metronidazole. Okay, all right. So we give 2 antibiotic. We send bus for culture or blood for culture. What else?
We give him something for pain management and to decrease
Okay.
the fever.
Okay, what else?
Antibiotic.
Okay. If this patient have pericolic abscess collection, not this anastomotic leak, just to make pericolic abscess, how to manage?
Okay, we can do it with the open or percutaneous one.
How to do percutaneous guided by what?
By ultrasound guided.
Percutaneous guided by ultrasound. But if it is complete peritonitis, what you will do?
We will do open. We will open.
And
we'll do a peritoneal lavage.
And
we will remove the abscess and put another drain.
Yes, but what the 2 end of the anastomotic leak, the 2 end of colon, what you will do for it?
I will do a.
What is the easy way? Just to bring it outside, what we call disease operation.
I think it's called the colostomy.
It is double. It is Hartmann procedure. It is colostomy, no problem. Okay, so it is a colostomy. Okay, so after that, is a patient, he developed oliguria in the post-operative period in ICU. So how to evaluate this?
Okay, it's according to the flow chart of the patient. I will look at it if he is having adequate fluid.
Okay, all right. What else?
I will also look for his CVP. He is having
CVP. What is normal CVP?
The normal CVP is 15.
15 what?
15 millimeter saline.
Centimeter saline. Okay. Centimeter saline. Millimeter mercury by special machine. You know what is fluid challenge test?
Yeah, flow challenge is giving the patient a 1.5 to 2 liters of saline or crystalloid over a short time, about 30 minutes to 1 hour, and see the patient's response. If the patient responds by the pulse is getting better and the blood pressure is getting better, so the patient is and the urine output is back to normal, like 70 milli per hour. So the patient is not in a shock.
So you mean that you give fluid 200 usually within 10 minutes, 5 minutes, so it's become normal. If it's still high, so it is hyperventilated, hypervolemia or hyperinfusion. If become high and low, is the patient is hypovolemic shock. Okay, so this is the CVP flow challenge. Okay, here I finish, but you ask first in the first, what you expect is this station?
I think this is acute surgical science and clinical care.
Actually, acute surgical science, basic surgical science, and critical care, yes. Because I found in the students or Turkey or other books, they write it is clinical examination. Actually, you examine the patient, but just examine the patient in 1 minute. just looking for the wound. You confirm that no drain. You confirm that low colostomy. So we have two mistakes. The surgeon removes the drain, and also he have no colostomy. So it is important in left surgery, left
Just have
colonic
a small
surgery,
comment.
myectomy, left hemicolectomy, anterior resection.
Okay,
It's better
just
to
a
have
quick
colostomy.
advice to do
Okay.
Dr.
Of
Nabhan,
course, the operation
because you
done.
are ready to go to exam in a couple of
Yes,
months.
bro.
Number one, they always
Yes.
provide you with paper and pen when it is a history
Yes.
station, and 90% of candidates don't use pen and paper, so it is more
Yes.
professional to write down the history. Secondly, it is a history station, so you spend around
Yes.
6 minutes taking history, and after the bell ring, you have 3 minutes of question. Professor Shireen Hariri have given you a lot of questions that come in different stations, but these are the commonest questions. So this is a good training. Secondly, I would advise you to have a checklist when you are taking history. So don't think, what should I ask him next? No, it wouldn't be this way. Is have a checklist, confirm a patient name, main complaint, history of the present complaint, past history, social history, is he living alone or not? And then you need to analyze things like analyzing pain score, radiation, intensity. And whenever you get patient with pain, you always tell him, shall I give you analgesic now? And he will tell you, I am all right.
Yes.
Shall I give you injection now? He will tell you, I am all right. Please go on. But you score point when you appreciate this. I have seen a lot of candidates. I am in severe pain. Okay. When the pain started, he doesn't even come to his mind to give analgesia, and you score less by this. So, number one, you need to create a checklist for history. And number two, it takes a habit to
Not
write
an
history
issue.
and to write it well. And we
Yeah.
usually provide paper and pen with any history station. So this is my advice to you, Dr. Nabhan. What's your comment to Professor Shireen? That's okay. Good luck.
Thank you very much.
Exactly.
All right.
Exactly.
Okay. Of
Exactly.
course, you don't take a history. If I say I have left hemicolectomy, you need to ask me what is the
Professor Shireen
indication. You have a
Al-Hariri, by
cancer,
the
you
way,
have
is very kind
diverticulosis.
examiner.
So, of
He
course,
is
it is
he
not
is
much
the
different because
kindest
this is the
examiner.
main indication,
But
but it's okay.
notice that he
Dr.
has a
Columbus,
smile in his face. You wouldn't get this smile in the exam.
yes.
You
Okay.
get what is called no prompting. No prompting
Yes.
in the examiner, which means you say something which is fantastically good. Patient have an AF, I will
All right.
consult with cardiologist, but you get a mask face. So you must get used to the, not to the smile of Professor Shireen Hariri, but if you have a mask face, because he is not testing only your information, he's also testing how confident you are
Okay,
with
thank
your
you so much.
information. Do you say it in a professionalism or not? So I know Professor Shireen is the kindest. He gives you smile. He gets a kind of nodding if you are in the right direction, and he stops if you are not in the right direction. But don't expect this in the exam. And
Yeah, no
sometimes you
problem.
get an angry examiner, which is sometimes bad. So you better get used to a tough examiner in order for you to pass. And you must
Okay.
get used to the habit of every history should be written down
Yeah.
with an essential element. Don't forget, are you living alone or someone
Okay.
with you? What are the social habits? And you didn't ask him about what is the cause of this operation. Is it cancer? Because he's 65. So these are important points to get high mark. Professor Shireen.
Okay, thank you so much. By the way, I think it's Nabhan or anyone enter. You know that in exam we have angry
Yes.
examiner.
Yes.
So the exam is two groups. We have like Bird and the Howick or something like that. So bad group and good group. Okay. So this is usually in the policy. So you need to expect it that in exam you have some aggressive examiner or aggressive patient. This is like pre-exam script. Like for example, today Dr. X is a bad examiner or angry
But
examiner. This man is
angry
good
examiner,
examiner.
yes,
So it
but
is like
angry examiner
actors in
will
movies.
not fail you.
So
He's
of
sometimes
course, you
not
need to
helpful.
correct that.
He has a masked face,
Okay,
and Professor Shirin
Carolus,
Hariri
you have
and
this
I, we
station
get
in exam.
assessment by the Royal College by the amount of examiners. So we either on the hard hook side, which is mean that we
Yes.
are tough examiner because they check our mark against all other mark for this candidate. I know Professor Shirin, he is on the very kind
Yeah.
side, but sometimes you get the angry side. But don't think that the angry side, yes, the angry side will make you fail. No, it's tough. You need to deal with tough examiner,
Thank you.
and you should pass still as well.
It is according to the position, I take it.
Yeah.
So yeah. Okay. All right. I think Carolus left because he's in emergency. All right. By the way, again, this is a station. What I mentioned is actually is the real station. They have patient have atrial fibrillation, and the patient, okay, it is history taking and quick examination, and it is under basic sign. It is a physiology or critical care station. Okay, most of the station like examine chest, examine the heart is not under clinical examination, although the students think it is clinical examination and concentrate in the examining of the heart and chest. Actually, we're not supposed to be expert in heart examination, but at least know how to auscultate, how to inspect and all this. Okay, of course, if the patient have AF, so it is better to have it's better to ask for oral anticoagulant later. It is important to patient to have TED stalking to avoid deep venous thrombosis later, all this. Okay, Carolus, he need to have lower limb anatomy. I think he's back. Carolus, you can speak or difficult? I think he's
lower limb with
difficult,
revision is
but
fine. I
okay.
think
So
Carolus
I have
is
lower
stuck.
limb. Is anyone need anything else? I am ready. Okay, we can start by lower limb again. Okay. Okay. So again, because we have it again before, I think next week we will start the history taken. We review all the history taken in exam because of the student who attend in September. So who need to start? For example, anyone? Dr. Muhammad, anyone? You?
I'm still with you. There is no
All right. Okay.
You need to share.
Nabhan. Okay. This is you see
Yes.
it before the median ligament, which structure related
which
to
is bottom called present now.
I
Which
can
is
see anything
screen
on
was
the.
on, yes.
all right.
Yes, we can see.
Yes. Okay. So okay, I share. Yeah. I see. You see it now?
Yes, I can see.
Yes. Median guinal point is indication of which structure?
Yeah, for femoral artery.
Femoral artery, and midpoint of inguinal between anterior spherical spine pubic tubercle indicate what?
Yeah, for the deep ring.
Deep inguinal ring. Okay. Big toe. What is the dermatome for big toe?
L5.
And little toe.
It's S1.
Okay. So I think it is L4. Just I make it enlarged. So big toe is L4 and little is S1. Okay. And usually the nerve supply is in this area. Which nerve? In the big toe.
The deep peroneal nerve.
Deep peroneal is the web space, and the other is superficial
superficial,
peroneal
around
and the laterally saphenous nerve. From where the saphenous nerve arises?
Saphenous nerve?
Yes, from another nerve.
Superficial femoral nerve?
Femoral nerve. We don't have superficial and deep. We have superficial femoral artery and deep, but nerve is only femoral nerve. Okay. You know, in the past, when we do varicose vein stripping, we do it from the side till the middle epicondyle.
Yes.
Nowadays, which level we stop stripping?
Above the knee.
Above the knee. So what you will do for varicose veins below the knee?
We can just inject it.
can injected or can something called multiple avulsion technique, just to make a holes, small tiny holes and avulse it. So why they change the policy of the stripping till middle malleolus?
To avoid injury to the saphenous nerve.
Saphenous nerve, to avoid injury of saphenous nerve. Okay, and again, we have here the lateral, you mentioned it, it is S1, and the innervation of the little 2 is by which nerve?
The
Shural nerve is okay. By the way, dermatome and the myotome is very fixed question in part A, part B. All right. Can you tell me about what is the middle boundary of the femoral canal?
Is the femoral vein.
No, not medial.
Femoral
is here.
Yeah, femoral vein.
This is lateral. No, not femoral vein. This is the canal. This is lateral. Middle is the lacunar ligament.
Okay, I understand the question.
Okay, this is lateral. Okay, so what is the function of the femoral canal? What is its function?
Yeah, femoral canal just allows to the expansion of the femoral vein to allow for the venous return.
Okay, and it is what is hernia here? What we called it? Which hernia?
Here, femoral hernia.
Femoral hernia. Okay, and the contain what you mentioned? It contains something. What is the
lymph nodes? Lymph nodes.
Lymph nodes. Okay. So what operation we do for femoral hernia? Ligate, we make suture between two structures. What is this two structure we can ligate it? Or suture? Or put mesh and suture? Lacunar ligament and?
Lacunar ligament and pectineal ligament. And the linguinal ligament.
Inguinal ligament is easy. All right. Okay. So it is important. Femoral canal is very important structure. This is ring and all this is very important. Again, I think I show you this before. So again, it is important to adapt it of this type of picture. Again, it is available in Get Through Anatomy or Matman Atlas of Human Anatomy. I will put it in the Telegram group. So A, what is A?
Is A?
Is a yes. Is a it is a gluteal region, and this is muscle is a landmark. You have a structure below, structure above. So what is this muscle?
This is the piriformis.
Piriformis. And what is P? Difficult, maybe P.
Superior gremlin.
And C.
I think D is the inferior gremlin, and this is the quadratus femoris.
Quadratus femoris, I think D. I check again. A, B, C, D, E. What is E?
This is the gluteus medius.
And F?
Gluteus maximus.
Nerve supply of medius.
Superior gluteal nerve.
Okay. So what is this artery M?
This is superior gluteal artery.
And L?
Superior inferior gluteal artery.
Okay, so if you have here again, A is piriformis, P and C. B is superior glomerulus, C is obturator internus,
Okay.
D inferior glomerulus. So you miss inferior obturator internus. Of course, J is quadratus femoris, and again, after that, of course, is a big sciatica. I within the nerve, not important. This is superior inferior gluteal. So superior gluteal nerve, J, supply which muscle? Two muscle. Which muscle?
Gluteus medius and minimus.
Okay. If something happened in this muscle, like affection of the nerve, what is the test?
Trendelenburg test.
What is Trendelenburg test?
Yeah, ask the patient to stand up and
so you stand in the left side, for example. What happened to the right side normally?
Yeah, normally the side the normal side will just be upward. If it,
so the normal side become upward. Okay, yeah. So this is very important. Okay, so if the patient is not normal, so it is drop. Okay, yeah. So what is the root value of superior gluteal nerve?
It's L4 S1 S2. L4 5 S1 2.
L5 S1 2. 5, not 4. This is important because Trendelenburg is common to be asked either in orthopedic or anatomy. Of course, we don't have picture like this in exam. All picture is plastinated or flesh without color. Okay, so this is important. Gluteus medius maximum, which is higher, nerve supply is
inferior gluteal nerve.
not inferior, yes. Not superior, inferior gluteal nerve, yes, correct. Okay, so we have another picture just used for this, another picture. This is the area of the femoral triangle. You can have muscle A. What is this?
This is the adductor magnus muscle.
No, adductor, not magnus. Magnus is
It's
magnus.
longus. Yeah, it's
longus,
longus
adductor
muscle.
longus. But what is B?
Sartorius muscle.
Nerve supply of it.
Yeah, femoral nerve.
Femoral artery. A, B, C. C, where is C? C here. What is could be?
This is the inguinal canal. Inguinal ligament.
Canal A, B, C, D. D, what is D?
D is the femoral. This femoral artery.
What is E?
The femoral vein.
What is G?
Superficial. I think this is the saphenous, long saphenous.
Long saphenous co-joint to the joint to the femoral. What is F?
F is the iliac vein.
No, iliac is difficult to see it. I just check again. F is the femoral vein itself. Because E is the artery. So again, A is adductor longus, B sartorius muscle supplied by femoral, C is the inguinal ligament, D is the femoral nerve more lateral.
Okay.
Followed by the artery, followed by the vein, and the vein we have long saphenous connected to it. This is what we do operation, saphenofemoral disconnection, Trendelenburg operation. H is gracilis muscle. What is the nerve supply?
Obturator nerve.
Obturator nerve. Are you sure?
Yeah, I'm sure.
Yes. Okay. After that, we have rectus I, rectus femoris, vastus medialis lateralis. What is the nerve supply?
Femoral nerve.
Femoral nerve. Okay. So it is the same. All right. Back again. This is the popliteal fossa. Of course, it is superficial layer, so it is from the back. What is A?
A is the biceps femoris.
Tendon. Okay. What is the E?
E is the semitendinosus muscle.
D
is semimembranosus.
B.
B lateral head of gastrocnemius.
What is H?
H is the common peroneal nerve.
No, common peroneum is more laterally.
Okay. So it's the tibial nerve going down.
What is G?
G is the tibial nerve.
Tibial nerve. Okay. And F?
F is the common peroneal nerve.
Common. If the injury of common peroneal nerve due to fracture in the head of fibula, what happened to the leg?
Foot drop.
Foot drop. How many compartments in the leg?
4 compartments.
Okay. So again, this is A, biceps femoris, B and C, head of gastrocnemius, D, semimembranosa, E have a long tendon, so semitendinosa, F is common peroneal because become laterally, G is the most superficial structure, which is tibial nerve, and H is sural nerve. Okay. If you come here, so nice picture. You can find the veins, the artery, the nerve, the common peroneal, the biceps. This is the reverse of the other. But again, this is for teaching. But the exam, we have this picture. Okay. This is cut of the lower limb of the leg, the TS, to see the compartment. So we have A, which is
tibia.
B
is fibula.
A, B, C. What is C?
C is soleus muscle.
What is D?
D is the gastrocnemius.
Okay. All right. A, B, C, D, E, F, G, H. So what is J, for example?
J is tibialis anterior muscle.
So it is related to tibia. Okay. H.
H is tibialis posterior.
Okay, I just check because I forget. So first, of course, A, tibia. So tibia is medial and B is fibula. So if you start by the way, because you start wrongly, C is the soleus because the gastrocnemius is more superficial.
Okay.
Okay, and the E is plantaris, which is sometimes not present. After that, we have this interosseous membrane, and we have H, which is tibialis posterior, so J is tibialis anterior. Of course, the lateral compartment is the lateral, so it is peroneus longus muscle supplied by common peroneal nerve.
Okay.
Of course, this is artery anterior compartment, so anterior tibial artery. We can have M, where is M? See M. M here is the peroneal artery. Okay. N posterior tibial, I think. N posterior tibial, and O is longus saphenous. Saphenous may be something here. Oh, longus saphenous. Okay. Sometimes it's difficult, but it's okay. All right. We have, this is, of course, femur. What is D?
Lesser trochanter.
What is muscle attached to it?
Muscle attached to the lesser trochanter.
Yes.
It's
We usually don't ask about muscle attachment. We don't ask you about muscle attachment. But if you ask you about muscle attachment, it means something important. You know, psoas abscess. No, not obturator. You know, psoas abscess.
yeah, psoas located. Yeah.
So it is iliopsoas tendon.
Okay.
Okay, so the next question, what is the nerve supply of iliacus and psoas? What is iliacus nerve supply? Iliacus muscle is supplied by?
Obturator nerve.
No, iliacus muscle supplied by the femoral nerve. The only branch or the first branch arises from femoral above the inguinal ligament. So iliacus by femoral nerve. Psoas by
Lumbar branches.
lumbar 1 and 2. Okay, so this is important. If the patient has psoas abscess, what it could be? What is the cause?
I honestly don't know.
Okay, so if they have something in the vertebral column, what could be?
Bot's disease or
Bot's disease, TB, yes, go correct. So Bot's disease or TB of the spine, so can cause psoas abscess. All right. So again, this is D is the lesser trochanter. Okay. So fracture neck femur. You have a vascular necrosis. What is the blood supply of the head of femur in baby and in adult?
the retinicular arteries in
adult, yes.
In adults and ligamentum teres in babies.
Okay, so which one of these picture can cause a vascular necrosis?
Subcapital neck fracture.
Subcapital neck fracture. So cause a vascular. What other bone in the body can have a vascular necrosis?
The navicular bone and the scaphoid bone.
The scaphoid may be common, navicular I think not common. This is the tendon of psoas. Okay, so this is iliopsoas, both iliacus and psoas. Okay. What is the nerve medial related to psoas muscle?
Psoas muscle, a genitofemoral branch.
No, something bigger. Obturator nerve. What is the nerve lateral to the psoas muscle?
The femoral nerve.
What other nerve is a group of nerve lateral to the psoas muscle from above? What is its name?
Yeah, the ilioinguinal nerve.
Subcostal, ilioinguinal, iliohypogastric. Suppose, which is rare, you injured ilioinguinal high up. What happened to the patient after that? Suppose you injured here, not in inguinal region. You have injured, you have appendix and dissected more deep. So you go to the posterior abdominal wall, you cut the ilioinguinal nerve. What happened to the patient?
He will lose the sensation over the
Not important because the genital branch of genitofemoral cover it. What else? This patient can develop a hernia, direct hernia. Why?
It should be because of the ilioinguinal nerve will supply the lower part of the muscles.
Which muscle? Conjoint tendon. He supplies the conjoint tendon. Conjoint tendon is the internal obliquus transversus abdominis. So this is very rare, but can happen. But what we see is the ilioinguinal, we see it in inguinal hernia is a superficial part, cutaneous part. You can cut it, no problem. Okay. This is the tibia bone. We have 3 muscle attached here, ABC. You know the name of muscle.
Yeah, this is the sartorius, gracilis, semitendinous.
So what you expect is the next question from me?
The nerve supply.
Okay, so it is important in exam to expect what is the next question. So suppose I ask you about the styloid process in the skull. You know, styloid process have 3 muscles attached. Stylohyoid, stylopharyngeus, styloglossus. So the next question automatic, what is the nerve supply of stylohyoid?
Facial nerve.
Facial nerve, stylopharyngeus.
Glossopharyngeal nerve.
What other muscle supplied by glossopharyngeal? No other muscle. No other muscle. No other muscle. It is glossopharyngeal supply only stylopharyngeus.
Okay.
Okay, and the third muscle is the styloglossus supplied by
Hypoglossal nerve.
Hypoglossal supply all muscle of the tongue except one muscle supplied by
Balatoglossus supplied by the vagus nerve.
balatoglossus or balatopharyngeus.
Balatopharyngeus, I mean. Yeah, balatopharyngeus.
I don't sure, but I think it's balatopharyngeus. If anyone can check. Okay, so back to SGS. So sartorius supplied by
Femoral nerve.
gracilis
Obturator nerve.
and sartorius gracilis and
We have a question
semitendinosus
by
by
Dr.
the sciatic
Mohsen
nerve.
Ahmed. He raised his hand.
Okay,
I
so
think he might have a
usually
question.
you expected what is the answer. So sartorius femoral, gracilis, obturator, semitendinosus, sciatic nerve. Okay, this is difficult. This is suppose it is cut section or something in the knee joint, and you can see here we have many mark. Can you? Yes, I don't see.
Okay.
Yes. Hi,
I
Dr.
think
Mohsen.
Thank you very much, Dr. Mohsen.
balatoglossus, not balatopharyngeus.
Balatoglossus. Okay. You check it in Google or something, or
I know
can
it.
check
Balatoglossus supplied by vagus.
balatoglossus. Okay, innervation. Okay, balatoglossus innervation. Balatoglossus is also balatoglossus supplied by vagus. Yes, this is balatoglossus. Okay, I just test balatopharyngeus just in case.
Okay.
Balatopharyngeus innervation.
Yeah, no. Balatoglossus supplied by the hypoglossal nerve.
No, balatopharyngeus is innervated by branch from pharyngeal plaques. It is okay. I just again because balatoglossus
Anyway,
is
the
supplied by vagus.
slides
Is
that
also
Professor
associated
Shirin
with
Hariri is
and
bringing
balatoglossus is
comes
supplied by
in the
vagus.
exam
And-
very frequent.
And
So I would-
balatopharyngeals is also by vagus. Both by vagus. But I don't know which one is the tongue. I forget this.
Yes.
So both by vagus, balatoglossus and the balatopharyngeus.
Okay, no problem.
Okay. I think the get through anatomy. It is whatever the college we have. The main college is the Royal College of England. So this is a museum of the college. Okay, it's not my museum. So what is the number here? Can you just tell me what is G, what is I, all this. Difficult maybe, but it's okay.
Okay, I can try.
Yes.
I think you mean G?
okay, you can start by J, I, start anterior or posterior, up to you.
Okay, we'll start with E. E might be a medial meniscus,
By the way,
Anterior, may, okay, all right.
and F is cruciate ligament.
F is, okay, all right. I just check again. Okay.
And G, honestly, G I don't know about it.
Okay. By the way, I check in the Google, so palatoglossus, not palatopharyngeus. So palatoglossus is a muscle of the tongue. Palatopharyngeal also supplied by vagus, but not muscle of the tongue. Okay.
Okay.
This is what in the picture. So we started by, of course, AB is a condyle of the femur, so lateral condyle, middle condyle, intercondylar fossa. So we can start from E, so anterior horn of middle meniscus, and F is anterior cruciate ligament, and G is anterior horn of lateral meniscus, and H is anterior, is a posterior. So here start the posterior. So this posterior horn of lateral meniscus, and after that I is the posterior horn of middle meniscus, and J is the posterior cruciate ligament. So if you found posterior cruciate ligaments, you can found F and J. So is the anterior and posterior cruciate ligament.
Okay.
Maybe difficult to remember, but it is important in exam. All right. This is can you enumerate the muscle of the posterior compartment? You mentioned it is 4 compartments. What is the muscle in the posterior group?
Yes, the C compartment, it's a superficial part and the deep part. The superficial part is gastrocnemius, soleus, and plantaris. The deep compartment is the flexor hallucis longus, flexor digitorum longus, tibialis posterior, and popliteus muscles.
Okay, all right. So 7 muscles, so gastrocnemius, soleus, maybe plantaris not present or present. Okay. This is patient. He is in the Lloyd-David position. And which nerve can be injured in this position?
Common peroneal nerve mostly.
Causing what?
Leg drop.
Leg drop. Common peroneal give which muscle?
Common peroneal nerve?
Yes.
Yeah, it gives the superficial and the deep, so it gives the lateral and the anterior.
Lateral, you mean lateral. What is the lateral muscle name?
It's the peroneus longus and brevis.
Longus and the brevis, okay. Of course, this is muscle in the front of middle malleolus. You can remember, we don't ask about it, but what we ask is the main inversion and eversion. So which joint is responsible for eversion and eversion?
Eversion and inversion? It's the subtalar joint.
Mid-tarsal, I think you can all do subtalar, no problem. What is a joint for flexion and extension?
Which joint?
Yes.
Yeah, it's the ankle joint.
Ankle joint, okay. So innervation, what is the root value is L4, eversion L5, S1 is very common question. Okay, what is the ankle jerk root values?
The ankle jerk?
Yes.
It's L5, L4, L5.
Okay. Knee jerk?
L3.
Okay. I check. Of course, this is a movement. You can find dorsiflexion, external plantar flexion, and all this, and movement of the knee. All right. You know what is this test for? Thompson test. What is this?
For the tendo-Achilles rupture.
Tendo-Achilles ruptures. Okay. So what you will do?
I will just let the patient. You let the patient just lay down on his belly, and I will let his leg hanging, and I will just squeeze his soleus muscle or his calf muscles.
Okay, so
if there is a plantar flexion, so it's intact.
What is the normal? What is the normal? Plantar flexion. So the normal
is plantar flexion.
If the patient
There's a
have
blunt.
DVT, deep venous thrombosis, what is Hoffman sign indicate? How to do Hoffman sign?
I
You
don't
know
remember.
Hoffman sign. Hoffman sign is the same also, but is the reverse. You ask the patient to dorsiflexion, they have pain in the calf muscle.
Okay.
Okay. I think this is about the muscle attached to this area is not much important. Okay. Because we still have a time, so I back to upper limb. Okay. What is the innervation of the thumb?
It's the innervation of the thumb. It's the
You
abductor.
mean the dermatome of the thumb? Which dermatome?
It's C6.
What about the other finger apart from the little finger?
It's C7 and the little finger is C8.
Okay. What is this structure called?
It's the anatomical snuff box.
What is the boundaries? Middle boundary, lateral boundary. You have one muscle, two muscle. What is the muscle here? What is the two muscle here?
Yeah, the muscle here is the extensor pollicis longus, and the two muscles here is the abductor pollicis longus and the extensor pollicis brevis.
Extensor pollicis brevis and the abductor pollicis longus. Okay. Or which artery in the deep here?
It's the radial artery.
Okay. We have loss of sensation in the web space, first web space. What is nerve?
Radial nerve.
Radial nerve. Okay. All right. This is the boundaries.
If we can ask you, Dr. Karim, can we have in the last 9 minutes, apart from the anatomy, to have something in examination?
Okay. No problem.
As
Okay,
the
just a
examination,
minute.
yeah, as the examination, the last.
What you need to examine?
I think we had the excision of nevus and the abscess.
No, you need procedure. You mean procedure?
Yeah, I mean the procedure. Yeah, procedure.
Procedure scale. Okay, can. Okay.
It was very informative for all of
share-
us as
share again, no problem. Everything is ready. Okay. Share. Okay, as we discussed last time, so we discuss excision of nevus, we discuss how to put a sample, we discuss wound debridement, okay, wound debridement, okay, deep wound, okay, deep wound, abscess drainage, we'll discuss it, abscess drainage, we'll discuss. So fine needle, I think we'll discuss fine needle or not?
yes, we discussed the fine needle aspiration.
Okay, so male catheter.
Yes,
so
I
male
have this.
catheter is okay. So in the male catheter, can you tell me what you start?
Yes, I started by greeting the patient and informed the patient.
By what? By what?
Greeting the patient.
Okay,
Like,
okay, all right. After that?
I let him know who I am and what's the procedure that we are going for, and I took a consent.
So can you tell me what is the procedure?
Yeah, I told him that this is a simple procedure done in many hospitals, and it's inserting a tube into the into your urethra.
You can say catheter. People know catheter. After that, what is the suitable size of catheter you choose? You need to prepare yourself first. So what is the size of catheter you use?
For males, we usually use 16 or 18.
What is mean by 16 or 18?
Yeah, it's a French size. Like
what is French mean?
For instance, it means the diameter of the catheter.
Not diameter. If diameter of the catheter is 16, means that the urethra is 3 centimeter.
No.
What is your answer? Anyone know correct answer? What is 16 French mean? It is the circumference. Okay? Don't worry. After that, okay. So you choose a catheter 16. You have what else you need to prepare?
Yeah, I need to prepare the local anesthesia, but
how to prepare local anesthesia?
It was written in the stem that the patient was already had the local anesthesia.
All right. So what you expected this local anesthesia?
Yeah, it's a clean gel lidocaine.
What is the percentage?
5% or 10%.
5% is 5%, no 10%. 5%. After that, what you will do?
I will start with having a sterile gloves.
Okay.
And start to sterilize the
Okay.
area.
So you speak in
Founded.
English, you have to sterilize.
Um,
What mean by sterilization? It is wrong, but it's not a sterilization. A sterilization, you put the penis in autoclave.
yeah.
This is preparation of the skin. Don't say sterilization. Very common mistake in Egyptian candid.
Yes,
After that, you
foreskin. I
prepare the
was just
skin. What
about
use for
to tell you
preparation?
that they always bring the specimen with
Betadine.
foreskin, and they don't know Egyptian
Betadine
what
or
to do with
saline.
foreskin.
Okay, what else?
Okay, so
How to clean the penis? What is the direction? Suppose
Yeah,
this is a penis.
from downward upward.
Whatever, there's to be one direction, but you need to make circle around the glans penis. You finish by the glans penis. Of
Okay.
course, in this mannequin, if you see this mannequin is not circumcised. So what you need to do first? Okay, no, expected. Okay, so first you need to retract the foreskin, and after that, don't forget to bring it back. Okay.
Okay.
After that, you clean the area. After that, what you will do?
After that, I will tell the patient I will start the procedure. If he
Okay,
feels
all right. What you will do?
I will just take the penis in my hand. I will
No. Before that, this is you need to test the catheter.
just
Outside, you need to test the balloon. Okay, if you go to any videos, traditional, we can share a video for you, or even in the people in Southeast Asia. The first you need to flush it or just test the balloon is working before you insert it. It must be done. Okay. After that, you insert. What is the position of penis? Now it is flat. Till you feel resistance. What you will do?
I will just back and I will just try to do it again.
No, you make the penis straight
Okay.
and insert it. After that, you can do any position.
Okay, may I
Okay.
just ask you about something, Dr. Shirin?
Can.
Yeah, when
You
Professor
always
Shireen
tell
said
us that to do things
you do
that
what
we
you
do in real
usually do
practice,
in your
and
hospital,
we
unless
Yes.
you are
don't really
outside the
do
normal regulation in United
you know,
Kingdom.
test the balloon
In
or
that
test the
case,
catheter
you don't
before
do
we
what
do
you
it in
do
real
in your
practice.
hospital,
Yes,
but you do
I know
what is
that, but
accepted
it
for
must
the
be done because
examiner to
it
let
is
you
inserted
practice
and
in
the
UK.
balloon is
So
ruptured or
this
not
is an
working,
important point.
so it is not good.
But it will be a little bit hard for us because you know the sterilization of the
Yes.
glove.
Okay. All right. No problem. I check for the notes.
Okay. Okay.
Okay. I will choose a picture. By the way, we prepare the catheter. So choose the catheter. You clean the area. You retract the skin of penis. You insert it after you test it. Up to you. After that, before that, we inject local anesthesia. It is 5%. So
There
I
is a
think this is up.
tricky.
After
Yeah,
that,
there is a tricky bit
you
in
can
this
reach
station.
here, so you make it straight.
Some
You
of
make
the
it
station,
perpendicular,
no urine
and
comes
after
out,
that, you
and they
insert it.
test.
After
Do you inflate the
during
balloon or what
insertion,
to
you
do?
must connect it to
And I
the
just
bag.
want you to
All right.
how
Okay.
to tell
After
the
that,
candidate
you
what to
inflate
do.
the
So you
balloon.
put the
How much you
catheter in,
inflating the
so far
balloon?
in, but there is
About
no urine coming
10
out.
milli of
So
saline.
what do you do?
It is written in the catheter the maximum you can. So can be 10, can be 5, whatever is written here. Both
Okay,
side by side.
what did you say?
After that, what you need?
I told them the beginning from the
Yes.
No, but you have now a catheter and you have a patient. So what you're going to do? Are you going to pull it out? Yeah. Excellent. You flush it and there is no urine coming out.
Yes, that
Because
was happened with
examiner
me. I
want to
had the
trick you.
same
If you said you
same
inflate the balloon without
station,
urine
and
coming
there is
out.
no urine came out with.
So what you will do?
I told him that I will check for the patient charge, as the patient at the beginning told me that he is thirsty.
No.
I will flush it. I will flush it.
Flush it. Okay.
Yeah, I will flush it because if there is any gel stuck in the catheter.